There we go. And so once again, you will receive a link to the recording following today's presentation. And nextly, a couple of other housekeeping things before we begin. First off, the session will run for about 60 minutes total, with roughly 45 minutes for the presentation and a bit of time at the end for discussion and Q&A. All participants are muted to reduce background noise. But you are welcome to post comments in the chat at any time. If you have questions specifically for our speakers, please use the Q&A feature to make sure it doesn't get lost in the chat. And we will be answering those questions at the end of today's presentation. Live captions are available today. So to turn them on, you're going to want to click the CC closed caption button on your Zoom if you would like to enable those during today's presentation. And so we do encourage you to participate. Please feel free once again to use the chat, put questions in the Q&A, and we will get to as many as we can by the end of today's presentation. And so with that, I would like to introduce our two speakers for today. First off, we have Dr. Kirby Stafford. He is the former chief scientist of the Department of Entomology and state entomologist at the Connecticut Agricultural Experiment Station. He retired in June of 2022 as an emeritus chief scientist after nearly 35 years researching ticks, tick-borne diseases, and tick management strategies. He continues work on several projects and manuscripts part-time. And then our second speaker for today is Dr. Robert Smith, who is an infectious disease specialist with Maine Health in Portland and director of the Maine Health Institute for Research for Vector-borne Disease Laboratory, which he co-founded in 1987. He has been involved in ecological, epidemiological, and clinical research on Lyme disease since his fellowship training, and he is professor of medicine at Tufts University School of Medicine. And so with that, we can go ahead and get started. So first on our schedule for today was Kirby. See, Kirby, you are on. Would you like to begin?
Certainly.
Awesome. And then I have the slides. Would you just like me to advance them for you during the presentation? Can you hear me, Kirby?
I can hear you. My talk is going to really focus on the discovery, emergence, and early history of Lyme disease from a mainly Connecticut perspective. Next. So Rocky Mountain spotted fever was the first human tick-borne disease identified in America from virulent cases in the Bitterroot Valley in Montana in 1906. Research on spotted fever and control of dermacentor ticks was a major focus of tick research in the U.S. for 3 decades. To give you kind of a Connecticut perspective on that, in the mid-1970s, Jorge Banach at Stony Brook, New York, and John Anderson and Louis Magnarelli began to work on an upsurge in tick-borne diseases in the Northeast, studying Rocky Mountain spotted fever, and began a collaboration with Willie Bergdorfer at the Rocky Mountain Laboratories. Next. But the recognition of Lyme disease began in Lyme and Old Lyme, Connecticut, due in part to efforts of 2 women. Polly Murray was one of them, the main one, and Dr. Alan Steer in the early 1970s. And this re-triggered a focus on human tick-borne diseases. But as you will see in the 2 presentations today, Lyme disease or Lyme borreliosis had a long history in Europe, and the focus of this presentation is on this Connecticut discovery. And a quote from Polly Murray's book, The Widening Circle: during the 1960s and 1970s, my husband, 4 children, and I were periodically plagued with mysterious symptoms. In time, I came to suspect that these ailments were somehow linked. And that's a picture of me with Polly at her house. Next. So in 1975, these 2 women who lived in the wooded towns in the lower parts of the Connecticut River began to complain about these mysterious health problems that were just previously alluded to. In early October, Polly Murray from Lyme, Connecticut, called the Connecticut Department of Public Health, and Dr. Schneidman, a CDC epidemic intelligence officer there, referred her to Alan Steer, who had been at Yale for only 4 months. He identified 35 children and 12 adults as having the mysterious disease, but decided it couldn't be juvenile rheumatoid arthritis. In late October, Judith Mintz in Old Lyme, Connecticut, also called the state health department after Mrs. Murray's call, and her daughter had swollen knee, ended up in a wheelchair, and was diagnosed with JRA, and her mom didn't buy it. Other kids had it. And then she called DPH, CDC, and was suggested she contact Alan Steer at Yale as well. Next. So in 75, in November, then Polly Murray had her first appointment at Yale University Rheumatology Clinic, and the Yale group and David Sneidman committed to their investigation of the 29 children and 12 adults with the mysterious disease. Um, Interesting, in 1976, two doctors in the U.S. Navy described 4 cases of the erythema migrans rash and was updated to 10 cases. In 1976 as well, the Yale group continued to connect these various manifestations of the new disease, pulling together information that had been present in Europe but never included in a large epidemiological study. And then in 1977, in the summer and the fall, the Yale group focused on insects and ticks and identified 43 residents in 12 towns around Connecticut River and found cases in ticks and mice more abundant on the east side than the west side of the river. And then Yale took an early role in the early Lyme disease surveillance to identify cases for clinical studies. Next. So Alan Steer was a professor of rheumatology now at Harvard University, now and then previously at Tufts University in Yale, and described Lyme disease in 1977 along with Stephen Malawisto studying that outbreak in Lyme, Connecticut. And the quote from that article, an epidemic form of arthritis has been occurring in eastern Connecticut at least since 1972, with a peak incidence of new cases in the summer and early fall. Its identification has been possible because of tight geographic clustering in some areas and because of a characteristic preceding skin lesion in some patients, thought to be a previously unrecognized clinical entity, and epidemiology suggests transmission by an arthropod vector. Next. Then in 1981, in that October, but Dr. Banach sends a batch of Ixodes damonii ticks, now Ixodes scapularis, to Willy Burgdorfer at the Rocky Mountain Lab. Spirochetes belonging to the genus Borrelia, an etiological agent of Lyme disease, was isolated from the midguts of the ticks by Dr. William Burgdorfer. In 1982, Burgdorfer, Barber, Banach, and colleagues published their work on discovering the long-sought organism in science. And then in 1973 was the first international symposium on Lyme disease held in New Haven, Connecticut. And then in 1984, the spirochete, the bacteria that causes Lyme, was recognized as a new species and named Borrelia burgdorferi after Dr. Burgdorfer. Next. In 1983, the Connecticut Agricultural Experiment Station was among the first laboratories to develop serologic tests for Lyme disease. And they did a collaboration with the Department of Public Health in 1984 and 1985 in order to try to get some population-based estimates of Lyme disease in the state. So therefore, in 1984, Lyme disease serologic testing becomes widely available in Connecticut, and the response was just overwhelming, with over 1,000 specimens tested in 1984. And then in May 1986, the Connecticut Department of Public Health stops taking specimens for Lyme disease testing and stops tracking the disease incidence. And then the experiment station supplied antigen to hospital laboratories. In 1986, as well, Polly Murray circulated a petition for more state help for Lyme disease victims. Next. This map shows you the distribution of Lyme disease cases in Connecticut based on that 1984 and 1985 testing survey. And as you can see, the highest density of cases is actually lying on the east side of the Connecticut River. That's the darker colors that you see, which kind of corresponds with what Yale found just a little bit earlier. Next. So in June 1987, Lyme disease was made a reportable disease in Connecticut, and a Lyme disease study group was established by the Public Health Legislative Committee meeting July 22nd, 1987. And also that same year, Connecticut authorized a tick position at the Agricultural Experiment Station, and I arrived in August to begin research on tick control. There was still no funding for Lyme disease for state health department at this point, although some funding was established in 1989. In 1988, there was the formation of the Lyme Disease Awareness Task Force under the Connecticut chapter of the Arthritis Foundation. And members include Polly Murray, myself, and Matthew Carter at the Department of Public Health with a focus on outreach. And the Arthritis Foundation in Connecticut had developed one of the first Lyme disease educational brochures at that point. Next. So in 1987 to 1989, we started seeing national media attention on Lyme disease. In July of 87, it was a cover story in Newsweek. And it also occurred in our Hartford Current here in Connecticut with some big spreads on it. And then Pfizer Central Research in Groton actually produced another educational Lyme disease brochure, one of the really best ones at that time. And they also sponsored several early Lyme disease conferences. So things were starting to move along. Next. Then in 1991, the first federal funding cycles for Lyme disease surveillance, education, and research began from the CDC. In 1993, the conspecificity of Ixodes scapularis and Ixodes damani, described by Dr. James Oliver, was done. In 1978, Dr. Andrew Spielman declared that Ixodes damani was a new and distinct tick species and the vector for both Lyme disease and babesiosis. But the name Ixodes scapularis had priority and the name reverted to scapularis at that point. So some of you may occasionally see reference to it as Ixodes damani, but that name is not really valid. Then in 1994, Doctors Anderson and Magnarilli published a review article in the American Entomologist. And then 1996, Polly Murray published her book, The Widening Circle on the Early Years and How the Medical Community Came to Recognize Lyme Disease. So if those of you that are interested in the early years of the emergence of Lyme disease, this is an excellent book to go to. Next, please. Then from 98 to 2002, it was the question, was it a vaccine preventable disease? Lymerix, it was taken off the market in 2022. Then in 1999, the CDC funded the first community-based Lyme disease prevention cooperative agreement to Connecticut. And then the following year, it was expanded to 4 states, Connecticut, Massachusetts, New York, and New Jersey. And in Connecticut, we were funded at 3 health districts. And it's kind of interesting, one of the health districts came up with their little Volkswagen tick mobile with tick symbols all over it got a lot of attention, and it was a good tool for outreach. Next. So why now? You'll see from these 2 talks, it isn't new. So what are the drivers of tick and Lyme disease emergence and expansion? Well, there's a number of them. Reforestation, habitat for the wildlife, overabundant deer population. Remember, deer is the key reproductive host for this tick. And ever increasing numbers of ticks, and indeed, this year is looking to be one of the record years for tick abundance and prevalence of infection. Expansion of suburbia into wooded areas, abundant habitat around the homes for these reservoir hosts, the mice, for example, increased exposure opportunities for people, as well as the geographic expansion of Ixodes scapularis from the narrow areas in the Northeast all down to the Mid-Atlantic and to the Midwest, and which was another focus, and then expanding northward in New England as well, all the way up into Maine now. So next. So there are some historical clues and findings of Borrelia and ticks in mice that also show that the disease existed long before this Connecticut discovery. Interestingly, for decades, doctors in the Montauk Point area of Long Island had talked about conditions they called Montauk knee and Montauk spider bite. Retrospectively, undoubtedly Lyme disease. The first case of Lyme disease on Cape Cod, Massachusetts occurred in 1962, which was diagnosed retrospectively from the patient's symptoms. Now, researchers have also found evidence of the Lyme bacterium in tick samples collected from Long Island in the 1940s. DNA sequences characteristic of modern-day isolates of Borrelia burgdorferi were detected in 13 specimens from Montauk Point and Heather Hills, Long Island. Data suggesting that the appearance of Lyme disease spirochete in the suitable arthropod vectors preceded by at least a generation the formal recognition of this disease as a clinical entity in the United States. Next. Studies detecting Borrelia burgdorferi, Cinchulatu, in European museum ticks have confirmed the historical presence of Lyme disease spirochetes with DNA identified in Ixodes ricinus specimens dating back to the late 19th century, with positive samples identified from as early as 1884. Again, it's not new. But Borrelia burgdorferi DNA was also found in museum specimens of Peromyscus leucopus, the white-footed mouse, collected between 1870 and 1919. Analyzed by PCR, two specimens from the vicinity of Dennis, Massachusetts during 1894 were reproducibly positive for Borrelia burgdorferi OspA sequences, and the agent of Lyme disease was present in a suitable reservoir host in the United States before the turn of the century. And these studies show that Borrelia bacteria responsible for Lyme disease have been found in specimens dating back well before the establishment of the government research lab on Plum Island, a common conspiracy theory, and also in mouse samples. And ticks in Europe, cases in Europe, as you will see later, and also in a 5,300-year-old mummy as well. Next. Otzi is the most ancient person diagnosed with Lyme disease from his DNA, so ancient humans probably contracted it as well. Dr. Alan Steer noted that this is proof that it goes back at least 5,000 years and probably a long time before that. He was so well preserved. They know the color of his eyes. They know a great deal about him, as well as all of his clothing, what animals they came from, and so forth. So it's really quite a remarkable discovery. And that really dates Lyme disease way back. Next slide. So the ancient history of Lyme disease in North America is also revealed in their bacterial genomes. Yale had a press release on August 28th of 2017. Researchers led by the Yale School of Public Health has found that the Lyme disease bacterium is ancient in North America, circulating silently in forests for at least 60,000 years, long before the disease was first described in Lyme, Connecticut in 1976, and long before the arrival of humans, so there was not imported from Europe by colonists, tied to the ecological transformation of much of North America. Forest fragmentation and the population explosion of deer in the last century have created optimal conditions for the spread of ticks and triggered this ongoing epidemic. The team turned to genomics to reveal the bacterium's origins by comparing Borrelia burgdorferi genomes collected from ticks in different areas, and over a 30-year period, the team built an evolutionary tree and reconstructed the history of the pathogen's spread. Again, a long history. Next slide. So a kind of summarized quote from Ackerman et al. In 1983 from that first international symposium on Lyme disease and the Yale Journal of Biology and Medicine in 1984. Lyme disease was found not to be a new disease. The Europeans had conducted research on Ixodes-related illnesses, especially the skin manifestations, for many years prior to the American discovery. Neurologic symptoms were described over the past century in Europe and in many different ways and known by many different names. And in the second presentation, Dr. Smith will get into a little more detail, on this. Next slide. So to wrap this up, I will just give you a quote from Pliny the Elder, the Roman writer. He described ticks as the foulest and nastiest creatures that be. And a quote from Dr. Anderson and Dr. Magnarelli from their article in the American Entomologist, which is still relevant today. The accumulating evidence suggests that in the years ahead, Ixodes scapularis will continue to expand its range, become more numerous, and become a serious problem for more people. Thank you.
All right. Thank you so much, Dr. Stafford, for getting us started and for giving us the wonderful overview of the history of Lyme disease. I see we have a lot of applause coming in from the chat. Thank you all so much for that. And with that, we'll head into our second part of today's presentation with Dr. Robert Smith. And so with that, I will hand it over to you.
Thank you, Emily. And thank you, Kirby, for that wonderful account of the early days of work of Lyme disease in Connecticut, as well as evidence that B. burgdorferi was circulating between ticks, mammals, and birds for millennia. We now know that this enzootic cycle was established across the Northern Hemisphere, is established across the Northern Hemisphere in a band from 40 to roughly 40 to 60 degrees north. So it involves areas of North America, Europe, and Asia. What I hope to do today is to take the clock back 60 years or so before the outbreak in Lyme, Connecticut, focused attention on the disease and to look at what the Europeans were seeing in terms of different aspects of this disease, starting way back in 1909. And not being from Europe, my apologies to anyone on the chat who is and knows more about this than I do. But it's really a nice history of astute clinicians making observations while busy with their clinical work and moving the field forward. It really was that cluster of cases, of arthritis cases in the 1970s in Connecticut that kind of provided the impetus and the team effort to try to get at the root of this disease. So we had a long sort of fuse burning around this disease, many of the observations coming from across the Atlantic. And then with the appearance in Lyme, Connecticut of these cases of arthritis that Kirby described, we really had an outbreak situation in a way that led to excellent work from epidemiologists, Alan Steer and his clinical team, vector biologists such as Kirby, and that whole story has been well told. I'll start with the first slide and take us back to 1909. And this is Dr. Arvid Afzelius, who is a renowned Swedish dermatologist. He trained with leading dermatologists in Vienna and Hamburg before he trained in Sweden and then went to continental Europe, came back and had actually written a textbook on dermatologic diseases in 1905. So he was well versed in general dermatology. He also had a private practice. But he saw something that was remarkable to him, despite all of that training, remarkable enough that he brought it to one of the early meetings of the Swedish or Stockholm Society of Dermatology. And I think actually the patient may have been present, as they often did in those days in these rounds, and was able to tell her story. But there are two key features. One, she had been bitten by a tick, and apparently they were able to say it was an Ixodes tick. That was at least the report. And then she developed this expanding erythematous rash that spread over a large part of her trunk over the subsequent weeks. And so this was a different enough presentation that Dr. Afzelius brought it to the attention of other Swedish dermatologists at the meeting. He called it erythema migrans because of the migrating aspect of this erythema flat red rash. Not too long afterwards, some other dermatologists, and I think without really necessarily knowing about Dr. Afzelius' presentation, reported, and these were Viennese physician, Dr. Balban, reported several cases which he attributed to insect bites. And then a few years later, another Viennese physician, Dr. Lipschutz, reported a case that had persisted for 7 months. So this person had a large area of erythema over their body that had gone on and on, hadn't responded to the usual topical treatments. And so he dubbed this erythema chronicum migrans, so modifying the erythema migrans that Afzelius had picked as the name. And that was really the start of some recognition in both continental Europe and in Scandinavia of a skin disease that was new and possibly of arthropod origin in terms of its a history of a tick bite. Next slide. There are differences. This is actually a North American case of erythema migrans. I show it simply because it shows the central some clearing, a punctum, and the annular ring, the annular aspect of it. But there's a nice study by Doctors Wormser and Struley in Slovenia comparing erythema migrans in Westchester County with that in Europe. and showing that actually they are different, and that the European version tends to be slower in onset, larger, with more central clearing, less association with systemic symptoms at the time of its onset, and so somewhat a slightly different picture, but on the same general scheme that we see here with a North American erythema migrans. These rashes usually appear a few days to sometimes weeks after the tick bite, and you may see the punctum of the tick bite only a third of the time. The next slide. Next slide, please. So this is moving forward, and we'll go back in a minute, but forward to the recent decades when we were able to use PCR and culture from skin biopsies to really expand the spectrum of what we knew to be the rashes caused by Borrelia burgdorferi. And this is just a kind of a scheme of several that don't really look so typical as the classic erythema migrans. I mainly show this because as time has gone on and we've had better tools, we've been able to really hone in on the what is and what isn't consistent with erythema migrans. And one thing I'd point out is the disseminated rashes, where you see multiple circles on the trunk in the upper left, are a feature of Lyme disease, both in North America and Europe. But we have about twice as many of these, if you look in our case series, than they do in Europe. So another difference. Also, probably these rashes were seen fairly early, so many of them haven't developed some of the more classic features. But in our studies of erythema migrans in North America, we've seen that early on, more typically, they're just a homogeneous red circle, or they may actually have an intensity of redness right in the center, but often don't have the typical bullseye pattern that you read about in clinical textbooks. Next slide. So that's the early recognition of erythema migrans in Europe. And while that was happening, not too long after those first reports by Afzelius, there were reports from different parts of Europe of an unusual neurologic disease. One of the first one actually was of this 38-year-old farmer, and the story was he'd had a sheep tick, which is an Ixodes ricinus tick, bite before developing severe pain, sciatic pain, weakness in his deltoid muscles, a rash that expanded from his buttocks to his left knee and his back, and had incomplete recovery at 4 months. And this case was just published as a case report by French doctors Charles Garin and Boujadou, but it was published in a local medical journal in Lyon, and probably lost to general readership pretty soon afterwards, in the days before we had Google. Unaware of prior reports of ECM or EM, they called this a case of tick paralysis. It didn't make a link to the previous studies of erythema migrans, but it is there in the literature. About 8 years later, going back to Sweden, which has had a major role in unraveling the knots of Lyme disease in Europe, we have Dr. Hellerstrom reports a case of meningitis in a patient 3 months after they'd been seen for an erythema migrans rash. Again, this is before the antibiotic era, so these rashes were seen, they would resolve, but in this case, after it resolved, this person came down with a chronic meningitis. And Dr. Hellerstrom went out on a limb and said, I think there's a link between this rash and a neurologic disease, which he published in a newly established Swedish journal, dermatology journal. And then about 14 years later in Germany, and this is the largest series so far, Dr. Alfred Banwerth, a neurologist, reported on an unusual triad of neurologic findings in 26 patients, some of whom had had some rashes, although he didn't really make the connection to erythema migrans either. But he did describe in detail this triad of a chronic persistent meningitis, cranial nerve palsies, usually seventh nerve palsies, and shooting pain in the distribution of nerve roots. Some, as I said, had rashes, but he wasn't sure what to make of this. Thought maybe it was a form of rheumatic fever or a strep-related skin infection such as erysipelas. It did later acquire the term Banwerth syndrome because he really had put this forward with a major case series in the 1940s before it was known what this was what the link was with Lyme disease. Next slide, please. So that's the neurologic disease. So we talked about erythema migrans. We talked about this triad of neurologic findings and maybe some early links between the rash and the neurologic disease. At the same time, and actually preceding some of the work we talked about with erythema migrans, the dermatologists in Europe, Dr. Buchwald being the first in Germany, but soon followed by Drs. Herxheimer of the Herxheimer reaction and Hartmann in Germany, described a different skin condition that was truly chronic. This was a swelling, usually asymmetric, as you see here, of a hand or leg with a doughy edema of the tissues, erythema. Sometimes it got a bluish color. Sometimes it could be uncomfortable. And this would just not go away. So these were truly chronic. And by that, I mean, can persist for decades. And so he gave it the term acrodermatitis, acro meaning extensor surface, and on the extremities, usually chronica, and then atrophicans, because over time, these tissues became very atrophic and sort of had an almost was described as a crumpled cigarette paper consistency. So this was seen, and the connections were not immediately made, of course, to anything else. But there was an anecdotal report once penicillin became available and it was being tried for different conditions from Dr. Nana Swartz at Karolinski Institute that this might be beneficial. In the late 1940s, again, a dermatologist, Dr. Thiersson from Stockholm, just reported that penicillin treatment of this condition had positive effects in the majority of cases. And I'll jump to this with EM too, but interesting, just jumping ahead, in the 1950s, they actually showed that if you transplanted tissue, and the volunteers were usually other people, other doctors who were on the team, if you took a skin biopsy from somebody with this condition and transplanted it into somebody else, you could get an erythema migrans rash afterwards. Fortunately, at that time, they knew they could try penicillin to treat it. Next slide. The other European condition, I'm putting these both in here because they're really not seen in North America, and we'll explain. We'll give you the reason why we think that is in a second. But the other one was something that was described in 1911 by Swiss pathologist Burkhardt, and it looked like when you did a biopsy, these little red swellings or bluish swellings were often on the ear in kids, or they were on the nipple. They could be in other areas, and they were just a persistent, somewhat sore swelling that on biopsy showed very dense B cell infiltrates, but they were polyclonal and did not look lymphomatous. The largest series was put forward by another Swedish dermatologist with 41 cases. But in that series, he was be able to link some of these to preceding erythema migrans and also to acrodermatitis chronica atrophicans. So now you have two different dermatologic conditions in addition to erythema migrans, and you have an unusual neurologic disease, all being reported from different parts of Europe by astute clinicians who are publishing their observations. Go to the next slide, please. So putting the pieces together, as was done in Europe at that time, it was felt that this seemed to be a bacterial infection that was maybe treatable. And since syphilis had been part of since penicillin had been part of the treatment regimen for syphilis, and which was a spirochetal disease, there was an attempt to say, well, maybe this could be something like that. It's sort of a relapsing illness, unlike things we've seen. It involves the skin, the nervous system. And so there were attempts to use bismuth and arsenamide, but penicillin really seemed to have some benefit, and even in cases that had neurologic disease. So this is a report from Dr. Holstrom from Stockholm again, of a series of cases with apparent response to penicillin, not just for the skin rash, but for the meningitis. And then in 1955, and again, we're 20 years before Lyme, Connecticut, Binder et al. Showed that you could transmit the agent of erythema migrans also by skin transplant from a patient to 3 volunteers, one of them being himself, and that they could treat themselves successfully with penicillin. So a lot had been put together in pieces from around the continent before we got focused on this in North America. And some really careful clinical work and experimental work had been done, but the agent remained obscure. You couldn't find it on normal pathological looks. You couldn't culture it. And so even though people were thinking about a spirochete, and even there was a false hope that they had found it, because in 1940s, one of the Swedish dermatologists found what looked like spirochetes on a biopsy from EM, but subsequently they were found to be an artifact. And so there had been a move toward a spirochetal etiology and then a backing away from it. Also, some of the knowledgeable vector-oriented physicians knew that relapsing fevers, spirochetal disease, due to that, was primarily a disease, was primarily transmitted by soft ticks, and these were hard ticks. So there was a lot of concern. What is this? Is it a virus? Is it rickettsia? Because they're hard to find, and that's where we'll leave off on the European story. Next slide. I'm going to jump back across the Atlantic now, and I know Kirby's already mentioned both of these findings, but I think it's important to point out that the first cases of erythema migrans were actually reported. The first one was reported from Wisconsin, not from the Northeast. And this is interesting in that this was the patient was actually a physician who was on a grouse hunting trip, came back with a expanding large rash on his chest, which was really unusual, and shooting limb pain. And this practitioner in Milwaukee, Dr. Rudolf Scrimetti, had, by his account, had read an article on tick-borne ECM with meningitis published by Dr. Hellestrom in the Southern Medical Journal, because Dr. Hellestrom had come to the U.S. to give a talk in 1950, had been published. And he'd read this as a student, and he'd been so impressed by the idea that you could diagnose, treat, and understand a disease simply by looking quickly at the skin of a patient, that it was one of the factors that led him into dermatology. And then, lo and behold, he sees the first case in North America in 1969 and publishes it after treating the patient successfully with penicillin in the Archives of Dermatology in 1970. And as Kirby mentioned, close to Lyme, Connecticut and Groton, Connecticut, at the substation, two other doctors, an internist and a dermatologist, saw a cluster of erythema migrans cases. They didn't know what it was at first. They described the rashes. They went to a dermatology conference at Yale, and I think someone there may have suggested there was a European literature on something like this, and they put it together and published this as a cluster of erythema chronicum migrans. And they wrote at the end of the article, to the best of our knowledge, it's the first appearance of a cluster of cases in the United States. Our cases illustrate the varying degrees of systemic involvement, ranging from minimally symptomatic chronic progressive skin lesion to a generalized severe illness. We hope this report will result in widespread recognition of this disease by physicians in the United States. And soon thereafter, as Kirby mentioned, it did, maybe a few years thereafter, once the Lyme, Connecticut story had come out. Next slide. I won't go into detail. This has been already mentioned, but Steer's first report was based on a retrospective study in pediatric and adult patients in 3 towns near Lyme, Old Lyme, and East Haddam, Connecticut. A quarter of them had had an expanding circular rash in retrospect. All of the cultures and attempts to look for an agent, including rickettsia and arboviruses, were negative. They reported this at the American Rheumatism Association in Chicago in '76, and it had immediate repercussions. The JAMA News Service said, what may be a new form of arthritis is reported from Lyme, Connecticut. Kirby showed you lots of other press that developed over subsequent years about these reports. And their case series was published in 1977 in Arthritis and Rheumatism. What I want to make a point about this is, I think 2 things that really made the difference here were, A, you had a cluster of cases, or B, you had them recognized by people in the community who reported them to both the state health department and then the state health department to rheumatologists at Yale University. And you had the capacity. You had at the state health department David Sneidman, who'd been trained at the CDC in epidemiology and was a keen became a renowned infectious disease physician. And you had Alan Steer, who had also been trained at the CDC and had come to do his rheumatology fellowship and postdoctoral work at Yale. And you had experienced clinician scientists such as Dr. Malavista as well. So you had all of the ingredients there, and you had the Connecticut Field Station with Kirby and his crew and Drs. Anderson and Magnarelli, who are already well versed in entomology and tick work. And it really took that infrastructure to propel things forward and get as far as they got in that first 5 years or so. Next slide. The other thing that they noticed and they confirmed was that they started with calling it Lyme arthritis, but quickly, once they were doing longitudinal studies, it became clear it was a multi-system illness, primarily involving, in their early studies, the neurologic symptoms, rarely Lyme carditis, which was a myocarditis with heart block. But the neurologic symptoms were very similar, reminiscent of Banworth syndrome that had been seen in Europe. And the Lyme carditis was something new that people hadn't seen in Europe, and arthritis hadn't been associated with this disease in Europe as well. So these reports, as reported by Eva Asbrink in 1986, really stimulated the Europeans to go back and look at other possible extracutaneous manifestations of the Ixodes ricinus, sheep tick-borne spirochetal infection in Europe. Next slide. And I won't dwell on these, but late complications we've already talked about, but basically there are several. Lyme arthritis is the primary one in North America. Acrodermatitis chronica atropicans has almost never been reported from the US. When it has, there are often people who've been in Europe previously, and there's a reason for that. And then there are rare cases of myelitis, encephalitis. Almost all have been reported from Europe. So why these differences? Well, we now know that there are different genus species of Borrelia. So in North America, it's almost entirely Borrelia burgdorferi sensu strictu, but in Europe, you have maybe 16 or something genus species, but you have at least 3 that have caused a lot of the illness. Borrelia afzelii, which is primarily responsible for the cutaneous manifestations such as ACA and lymphocytoma. And you have Borrelia guerini, which is primarily responsible for their predominance of neurologic diseases such as Banworth syndrome and the rare cases of encephalitis. Next slide. So all of this was coming together, and this, unfortunately, I missed this conference. There've been, just in Chicago, was number 17 of these conferences last fall. It's been really a wonderful thing that Alan Steer put together right off the bat, and that was an international conference to bring the European researchers, clinicians, epidemiologists together with those in North America. And the wonderful thing about these conferences are that they're multidisciplinary. So you really, if you go to it, its focus is on Lyme disease and borreliosis, but the presentations range from new epidemiologic strategies to microbiology, basic science, and clinical work. And when you read this, if you ever have a chance to look at this journal, it really is a wonderful mix of the observations we've just talked about from Europe and from North America. The other thing that's in this journal is that when people started doing case surveillance, such as Kirby mentioned in Connecticut, but you did it in New York, New Jersey, Minnesota, and Wisconsin, it was clear that Lyme disease was already occurring in these different endemic areas at the point at which they could report. You can see the numbers here, but 100 cases or so in each of these states. Some of them in Wisconsin from all 22 different counties. They were heavily weighted by having more complicated Lyme disease, because at that point, of course, we didn't know what the agent was, and people were not being routinely treated, and erythema migrans was not routinely recognized. So this was I think a bellwether moment, a watershed moment in the field. Next slide. I won't go through this. Kirby already covered it, except to point out that the work on Borrelia burgdorferi helped to explain the differences between what we saw in North America and Europe. And they were very quickly able, within a few years, once the agent had been identified, to definitively link all of these clinical manifestations to B. burgdorferi infection. Next slide. Soon after, and actually before the agent was really known, Alan Steer started studies of antibiotic therapy based on the European experience. for treatment of early Lyme disease. And these studies showed benefit. They showed prevention of complications of Lyme disease and that EM got better quicker. And so this was the first, these were the first studies of maybe now 12 or more RC randomized control trials of antibiotic treatment of early Lyme disease. Treatment for later Lyme disease, there were fewer trials, but they were started early. Here, of course, the focus in North America was on Lyme arthritis. In Europe, it was more on the neurologic manifestations. But these studies definitely showed not only do we have an infectious agent, we had treatments that were beneficial. They also showed that 5 to 35% since these early studies of people treated early still might have residual symptoms or different symptoms at 6 months that meant they could not return to health. So they had persistent fatigue, myalgias, or cognitive symptoms following what appeared to be effective antibiotic treatment. Next slide. Why, we've already kind of talked about this, why the different presentations in the two continents, and I think it's pretty clear that this has to do with differences in the Borrelia genus species that predominate in North America versus Europe. Go to the next slide. And this is just a pure speculation, but why the delay in putting these pieces together? And you can come up with a number of these possibilities. I think early on, certainly these were sporadic cases in Northern Europe. And you look at Azalea had 6 cases in an active dermatology practice with an interest in this disease over 15 years. So they weren't seeing a lot of it, and it resolved on its own. And most of these patients had no other symptoms. So it was a yes, interesting, but it's going away. And similarly for the extracutaneous disease, for the most part, it resolved on its own. Not always, but for the most part it did. And we have exceptions with both neurologic disease and arthritic disease we know of now. And also there was no mortality until we saw a small number, fortunately, but that does happen of cases of fatal Lyme carditis. There was very little pathology available except for skin and joints, as previously mentioned, and no infectious agents were found until the 1980s. There was no way to really communicate quickly about, they have different reports in different journals in different countries, different languages, at least in Europe. And you have disease findings that are going, funneling into different silos, dermatology, neurology, and here rheumatology. So I think it gets back to why was Lyme, Connecticut so critical? Well, you can see it was really when we were able to put all of the effort together to with teams in that group to get to the to describe the disease and to get to the cause. Next slide. So what we've learned, as Kirby said, Lyme disease is not a new disease. Ixodes scapularis range extension is due to ecological changes coupled with human residential patterns, and there's a deep literature on this. And this led to the full recognition of disease following the outbreaks in coastal Connecticut, and that there are differences in the disease depending on what the genotype is. Next slide. And I don't want to get into the weeds too much here, but I think it's important to show all of the work going on with co-infections of deer ticks and with newly recognized infections. And just a couple of points. Human granulocytic anaplasmosis probably wouldn't have been diagnosed by a specific agent if we didn't have PCR. You see Science Molecule of the Year in 1989 was Taq polymerase. If that wasn't available, it wouldn't have been possible to figure that out. But it was an astute ID, I'd like to say, clinician in Minnesota who saw a patient who died from some sort of odd febrile illness and noticed that intracellular inclusions were on a blood smear and had the curiosity and drive to see that those got sent down to an expert in Texas who was then able to take it to the next step to look genetically. And that's how we learned about anaplasmosis, first called ehrlichiosis. With heart tick relapsing fever, sort of the opposite story in that the bacteria was found right away in ticks were 1995 in Japan, in 2002 in ice caps in the US, but we didn't know if it caused a human disease until a Russian, Dr. Platonov, who was focused on tick-borne diseases, published a series in EID in 2011, and our first case reports were in 2013. So even now in this century, we were had a little hard time figuring out whether something found in a tick is actually a pathogen or not. And then, as many of you know, there have been a series of other tick-borne diseases described, some carried by Lone Star ticks, some carried by deer ticks, and just in the last decade or so. And finally, there's one that hasn't been solved. Southern tick-associated rash illness looks just like erythema migrans, described in Arkansas and Missouri in 89-90, is strongly associated with Lone Star tick bites, but no infectious pathogen has been found, despite a lot of effort in the past, including use of modern molecular genetic techniques. Next slide. So I want to wrap up right now. I want to give you time for at least a few questions, but just you might, for those of you, particularly those involved in vector-borne disease work, you might want to look at Lars Eisen's recent paper just this month on why the ticks are winning and what we can do about it. Also, Derlin Fish, who's a longtime Yale and vector ecologist and biologist, wrote a nice provocative opinion piece getting serious about tick-borne disease, New England Journal just last week. We need to improve our diagnostic treatment strategies in addition to better preventive strategies for tick-borne disease. And we need to understand the mechanisms of persistent symptoms post-treatment. There's a recent report, consensus study report, talking about charting a path toward new treatments of Lyme infection-associated chronic illnesses. Next slide. One more second. Just as I look back over this literature, and it reinforces again the importance of having astute clinicians, well-trained, supported clinicians on the front lines, the capacity to investigate new things with availability of academic medical centers and their emphasis on discovery and creation of new knowledge, CDC and NIH expertise and funding. All of these were critical. Shared information systems for new observations, which of course is something that we're seeing more and more of. Laboratory systems using the latest approaches to pathogen detection and immunologic evaluation, and with people who are trained in expert interpretation. And then the infrastructure to actually bring these things back to the clinic or the bedside or the residents, whether it's a preventive treatment or a diagnosis or a treatment or a new treatment. The last slide. Just some historical notes for those who want to delve into any of these early. The first three are by major figures in the early days of discovery of Lyme disease. Dr. Damon was a very well-known pathologist in Boston who wrote a nice review of E. migrans back in '89. Dr. Thiverson, who I mentioned earlier, was a dermatologist who wrote a nice historical note on Lyme borreliosis. And John Edlow's Bullseye, which is a good read for people who want a lot of the stories in more detail. And I'll stop there. I'll show you my disclosures and then I'm done. Okay. Thank you.
Great. Thank you so much, Dr. Smith, for giving that wonderful overview of Lyme disease, both in North America and in Europe. Once again, have lots of clapping, thumbs up coming in from the chat. And before we start getting into Q&A, which we will very quickly, just a couple last housekeeping notes. First off, want to make the note that this presentation was for educational purposes only and is not a substitute for medical or veterinary advice. If you are interested in learning more about ticks and tick-borne diseases, we do have some webinars coming up soon. On June 9th, we have a webinar on best practices for risk communication for emergent threats. So if you work in public health, medicine, or related fields and interested in learning more about that, you can join this webinar here. More information will also be put in the chat. And then we do also have some upcoming webinars in our Biting Pests series, one in June on alpha-gal syndrome. I saw we had some questions in the chat about that. So if you'd like to learn more about alpha-gal syndrome, please join us on June 30th for a presentation specifically about that topic. And then we will also be having a webinar in July on longhorn ticks and cattle health, so more from the veterinary side. Lastly, if you'd like to learn more or stay up to date, we have some newsletters. Please feel free to sign up for those. And very, very lastly, we do have, as always, an evaluation for today's webinar. So if you'd like to let us know what you thought, let us know about ideas you have for future webinars, any other notes that you don't get to today, please fill out that evaluation. It really helps us as we plan out these webinars and pick out topics that people are interested in. And with that, I'm going to stop sharing my screen and we can get into the chat with the little bit of time that we've got left, or get into the Q&A, I should say. So let's see, going into the Q&A, we've got a few questions about these, so I'll start with, is there any work on developing a vaccine for Lyme disease and other tick-borne diseases?
Well, yes, there's a phase 3 trial just finished for a Lyme disease vaccine that Pfizer or Valneva put together, and the preliminary results were just made available. They're going to the FDA to see if it will be approved. There are other initiatives underway with some different approaches, and there's a monoclonal antibody that's being studied as a preventive. So there's some interesting work going on in terms of Lyme disease prevention. What would be really the holy grail would be if you had an anti-tick vaccine, I think, so that you if that were ever possible, and you would know the tick is biting you immediately, and it would drop off you, and you wouldn't get any of these other diseases. The trouble with just a Lyme vaccine is, of course, we have more work to do for the other agents.
Thank you. So there's one other another question that we have. They said, I'd like to discuss the issue of prophylaxis with 1 dose of doxycycline for tick bites. They've read varying opinions about it. So any comments on prophylaxis?
Well, it's been shown to be effective in a couple of different studies in the US and one in Europe for treatment of people who've been known to have a deer tick or Ixodes scapularis, black-legged tick bite within 72 hours, given within 72 hours of removal. And what it showed in the largest study in Westchester County was a drop from about a 3 to 4% development of Lyme disease to a 0.5% or so. So that's like an 80% drop, but it's from pretty low numbers to begin with. So the general recommendation is try to be sure it's a deer tick. It may be helpful if it's been feeding and engorged in preventing Lyme disease, and it's used a lot. There's a pediatric recommendation as well as an adult, which is relatively new. I know Kirby may have some thoughts on that since he's been involved in a lot of the education on this.
Well, it's just a reminder that, transmission is not immediate. Powassan virus is an exception to that, but fortunately, it's still a relatively rare disease. But Borrelia, it does take time for the spirochetes to make it to the mouth parts of the tick and get injected in, so to speak, in the feeding process. So those early tick checks are very important. So even if the tick is infected, you get it off, you're not going to get infected.
Great, thank you. And then we had 2 related questions, so I'll ask them both at the same time. One was, is there a new, more reliable test on the horizon for Lyme disease? And then the other question was, what lab tests can be done to check for the presence of these pathogens? Would they be available at a place such as Quest?
So the second one first, there are good tests available for other pathogens, and they will vary depending on where you live, because if you live in a place with a lot of Lone Star exposure, it's going to include some slightly different, you'll have Ehrlichia, for example. If you're up in Maine where I am, then where we don't really have Lone Stars in any number anyway, it's going to be primarily focused on Anaplasma, Babesia, and Lyme. The tests are really good for the other agents because they're PCR tests, and those agents are in the blood. It's harder for Lyme disease because we're using antibody tests. We don't have a good direct detection method, and so you're looking at a negative results in the first few weeks in about half the people, because it takes time to get your antibodies at the level where they're detectable in testing and where you can rely on them. So it's actually Lyme disease is the tougher one in terms of an early direct test.
Great, thank
And you
you.
might make it clear, Rod, that, it's partly because the spirochetes don't stay in the blood, unlike the other
Right.
pathogens that are, yeah.
Yeah, no, that's right. So they're in the next to collagen and in cutaneous tissue. It's hard to find them in the blood. You have to work really hard. It can be done early, but it's hard. Yeah.
Great, and then we are just at about 1 o'clock. We do have quite a few questions left in the chat, so I did want to ask Dr. Smith and Stafford, are you guys okay staying on for a few more minutes to get through a couple more of these questions, or do you have to head out?
I can stay on for a bit.
So can I.
Perfect, thank you. I didn't want to keep steamrolling through the questions if you had to get off, so thank you for staying a little bit late. Another question we had, and I believe there was some discussion in the chat about this as well, was any thoughts on the 60-minute story Sunday about the research from Yale and MIT researchers about changing the DNA in mice for possible release on Martha's Vineyard?
I'll defer to Kirby on that one. I know about it's interesting work, but I'd be interested in
Yeah,
your.
it's an interesting concept, but there's a reason they're doing it on an island. Actually, there's several reasons they're doing it on an island. And one, of course, is you have a confined population, so to speak. Even if it works, I'm not sure. The question is how practical that'll be on a more mainland type of setting, where the mice are ubiquitous almost everywhere. Um, so that's a question. And then there's also questions of what kind of ecological consequences might be, you know, by modifying the genetics of a free-ranging wild species.
There's also the possibility that other creatures may serve as reservoirs. So we've had examples in sort of islands in Maine where we, for whatever reason, don't have mice, and we've had other rodents that were able to serve as reservoir hosts. So these like all of these strategies, they have to be tailored to the particular ecology and mammal community that you have that you're dealing with.
That's true. I mean, there have been studies that have noted that mice were not the most abundant reservoir hosts, and chipmunks were actually quite abundant and played the role in that regard, and shrews. Shrews are also reservoir competent for Lyme spirochetes.
Yes, absolutely. Very good point that, yeah, these ticks, especially black-legged ticks, will feed on all sorts of different animals. They are not particularly picky all the time about what animals they are attaching to. So yes, it gets very complicated. All right, so moving into a few other questions, specifically about Lyme disease and Lyme disease symptoms. So for Lyme disease, is the rash always localized to the area of the bite? Or in other words, if you got bit on the foot, could the rash show up on your chest or face, but not on your foot?
No, it's localized to the site of the bite with one exception. So the the it, the bacteria are inoculated in at that site, and they move out radially from the inoculation site, and that's what causes the annular or circular erythema that is the telltale sign of very early Lyme disease. The one exception is that if it becomes disseminated in the blood temporarily, you can see these multiple EM rashes appear. So usually there will be 5 to 10 of those circles. There might be an inoculation site and then a bunch of secondary lesions that are all due to the Borrelia, but it all came in on one inoculation site.
Gotcha. And then a related question. So this is more generally related to tick bites. I've heard several people say that they get itching or inflammation around a previous or old tick bite when bitten by a tick elsewhere on their body. Could you share why that may happen? If there are publications I should look into for literature to be more informed on this? Thank you.
Kirby?
And they clarify, is that you're talking about inflammation at a previous tick bite?
Yes, I believe so. So if you're bitten by a tick, not necessarily, not necessarily related to Lyme disease, but just generally speaking for tick bites, if they've been previously bitten by a tick, if they're bitten by a tick elsewhere on their body, could they get itching or inflammation around an old tick bite site or in general?
I haven't heard about inflammation on old tick bite. I mean, it's healed and it'll be over. However, people that have been bitten frequently can develop a sensitivity to the tick bite itself. Polly Murray told me many times that, she'd been bitten enough times that she always knew when she had another tick bite. She just, she had just a general reaction of not feeling well. It was something that she could really cue in on. So in that regard, you can have a reaction, a more systemic reaction to the tick bite. It's another tick bite itself, because you build up a sensitivity to it.
And sometimes you get a little granuloma, say the
Yeah.
mouth parts or something are in the skin, and that can take a long time for the skin to eject that foreign material. So that, sometimes people will have an area with a little granuloma for weeks to months after a bite, and it just takes a long time to get rid of that, the chitin or whatever it is the tick has left in you.
All right, moving right along. Next question. Is there a particular blood type that is more susceptible to being bitten by ticks?
Not that I know of.
No, I mean, not blood type. I mean, it's kind of a well-known pattern that some people are tick magnets. Um, there are people, and this is all kind of anecdotal. It's never been like formally studied in a scientific study, but it's clear there are people that go out and don't pick up very many ticks, and then there's other people that'll go out and pick up a lot of ticks. It's just like mosquitoes too.
I was going to ask about mosquitoes, whether that's been shown with mosquito bites or not. Oh, apparently not, right?
Yeah, no, I no, there may
Yeah, I
be
think
some different chemistries. I mean, a tick uses, carbon dioxide, other body odors, vibrations, other, ways of detecting the presence of a host, and that may vary somewhat from person to person. Not well understood.
Yep, that's my understanding as well, is there's a ton of anecdotal evidence out there about some people, like you said, being tick magnets. So some people getting bit by ticks more than others, but the exact reasoning is maybe not quite as well known. But that is certainly something we see. All right, a couple of somewhat related questions here, which you talked about some of these a little bit briefly during your presentation, but I'll revisit these in the Q&A. First off is the incidence of Lyme disease increasing nowadays? And then the second question was, are there any tick-borne diseases in Africa, Asia, and South America? And how widespread is Lyme disease? So do you see Lyme disease outside of North America, Europe?
So the second, in the Lyme disease is most commonly reported in that northern hemisphere temperate zone band at 40 to 60 degrees. There are reports from around the world in different places of possible cases. I don't know how well substantiated they've been, but certainly tick-borne diseases are a big problem all over the globe in different forms. So you have relapsing fever in parts of Africa. You have rickettsial disease pretty much everywhere, different rickettsias that can be carried by ticks. So it's a big issue. Actually, there was a recent report in our infectious disease literature from Uganda, I think, of pastoralists, people who herd animals and are out in the wilds a lot, coming in with fever, and everybody would check for malaria, and we're finding it in some places. And when they started doing specialized tests for rickettsial disease, finding that that was a significant contributor. So I think there's probably a lot more of it going on in places that don't have a lot of resources devoted to looking at this than we know about.
Well, I've actually published a few papers related to exotic ticks coming on Americans coming back from vacations or travel in Africa. So it's just something to bear in mind if you're traveling overseas, particularly if you're going to Africa on safari type trips or even in Europe. There are, you have that sheep tick, resinus, but you have new diseases that are emerging in Europe besides Lyme, and so that's something just to be aware of, is that you need to be cautious about tick bite preventions, even when you're traveling, overseas.
Yes, yeah, very good thing to keep in mind. Exactly, even if you're not traveling around Pennsylvania or the Northeast or wherever folks are tuning in from, it's good to be on the lookout for when you're traveling. To go back to the first part of that question, which once again I believe you mentioned briefly during your presentation, but are we seeing cases of Lyme disease increasing, like here in the United States?
I don't think that's an easy question to answer. Part of it is that the surveillance definition has changed. So in the high endemic states now, it's based on lab reporting rather than reporting ECM or erythema migrans, I mean, and lab. And so with a changing baseline, it's hard to know for sure. I'd say they're probably in some areas it's definitely increasing. So there are areas where the tick is just getting established, say between the hotter areas in the upper Midwest and the Northeast. There are states that are seeing more Lyme disease in between, and the numbers are definitely going up. In places where there's been a well-established and zoonotic issue with beaver dorfry and the ticks, it's harder to say whether we're at kind of an equilibrium. I mean, most of these things level off at some point, but here in Maine, the numbers reported go up every year. But as I say, we've changed the baseline, so it's a little harder to know how to interpret it.
Definitely a bit, somewhat of a complicated question to answer. Absolutely. All right, we'll go through a few more questions before we start wrapping up for the day. First off we had a question towards the beginning of the presentation. Is there a reliable guide to identify ticks that physicians can use? So any tick identification resources y'all recommend?
There are some basic keys that are available. There's one that was published a number of years ago in the Journal of Medical Entomology. Um, the thing to bear in mind is that identifying basic keys that identify the major ticks that you're going to encounter, the common human biting ones. There's about 12 or so that are of medical veterinary importance, although there's a record of 40 species that have bitten people. Um, when you get into identifying a lot of these other ticks, remember most ticks are actually specialists and as opposed to generalists, which is why Ixodes scapularis is such a problem because like you mentioned earlier, they feed on so many different hosts. But a lot of ticks are actually quite specific. And I'll give you one example that you may not be aware of. Ixodes banksii. It feeds on beavers. So unless you're dealing with beavers, you're unlikely to encounter it. So basically, when you start trying to key out all the known Ixodes species in the United States, it gets really complicated and it gets really challenging, using a key. But for identifying your basic species, what do you have? You've got Ixodes scapularis, you got deer ticks, you got the Lone Star ticks. We're starting to see Gulf Coast ticks, moving up the coast. We have them in Connecticut now. You have the new longhorn tick. It's a recent import, invasive tick that is rapidly spreading. So you just have a handful of ticks that most clinicians and most people are actually going to end up encountering.
I'm going to have to sign off for another meeting, but thank
No
you.
worries at all. Thank you for
Thanks,
staying
Rob.
on late, and thank you again for presenting today's presentation. Really, really appreciate it. All right, and then let's see. So we had a couple of last questions. So Dr. Stafford, if you want to take about two more, then we can wrap up for the day.
Okay.
All right. So one question we had on here was, why can't people take anti-tick meds that I give to my dog? So we have a lot of veterinary options out there for tick bite prevention. Why can't humans use those?
Well, it's a different process in authorizing medications for pets and companion animals versus humans. And so getting FDA approval for these and going through the whole clinical process of proving whether they work is a whole different ballgame.
Yep, exactly. And another point I always like to make whenever we're talking about tick control for companion animals is there's a lot of tick control or a lot of tick management options out there for dogs and cats and other animals. But yeah, always good to make sure that you are using whatever method you're using on the animal that it's labeled for. So dog products for dogs, cat products for cats.
Yeah,
Always really
not
good to
use
keep
them
in
on
mind.
you, but
Yes, and not use them on you. Exactly.
if you're out there just, and real tick infested habitats, long pants tucked in the socks. Remember, ticks are basically down mainly in the lower vegetation. Um, and so use a repellent. And I will say that there's permethrin treated clothing that you can buy now, in addition to a spray that you can apply to your clothing before you put it on. It's extremely effective. And I will say, in 35 years out in the field, I had very few tick bites and I never got Lyme disease. So, take those tick bite prevention measures. They work.
Yes. Fan Fantastic point, I guess. There are a lot of prevention measures that people can take before they go outside. Treating clothing with permethrin is a big one that I also use all the time whenever I'm doing any sort of field work outdoors, and they are really effective. So being prepared can be really, really helpful. All right, we'll do two more, last two here.
Okay.
One question was, can doxycycline reactivate the Borrelia burgdorferi in one system?
Can repeat that, please?
Can doxycycline reactivate the Borrelia burgdorferi in one system? So if somebody was bitten by a tick at some point, had been infected with Borrelia burgdorferi, would doxycycline be able to reactivate or interact with that in some way?
That's a clinical question that I have not seen anything that relates directly to that myself, in the literature, but then that's starting to get a little bit out of my territory.
All right. Yeah, I will. Yes, I is also out of my territory, but I've also not heard of anything like that before. But yes, more on the clinical side outside of sort of our expertise here. All right, and last one, which this is also a little bit more on the clinical side, so we can skip over it if we cannot answer this at this time. But there was one question. Suzanne said, I've been diagnosed with Lyme disease 3 times over many years, and the test results list several aspects that will always be positive once you've had Lyme disease previously, but others that are used to indicate new infection. But my rheumatologist disagreed with that information on the blood test results. What will a new case of Lyme disease show on a blood test?
Well, generally, you're talking about the type of antibody response. So your IgM antibody is something that appears in early infection and then disappears, and then your IgG antibodies show up, and they're much more persistent. And yes, you can have a positive test long after that initial tick bite, despite successful therapy or antibiotic treatment, and I define that as being no symptoms. You're basically over it, but that is true. And by looking at the antibody response, sometimes I can make that kind of determination, the type of antibody response.
All right, thank you. And with that, I think we've gone through most of the questions that we had. So first off, thank you everyone who is on the call for staying on late for the Q&A. Thank you, Dr. Stafford, for your wonderful presentation today. Got to log off early, but also thank you to Dr. Smith for his wonderful presentation as well. I will throw up one last time because we had to go through them a little bit quickly earlier. If you're interested in learning more about any of these topics, we do have some upcoming webinars. Once again, on June 9th, we have a webinar on best practices for risk communication for emergent threats. So for anyone who here works in the medical, public health field, any field where that would be applicable to you, feel free to tune in. And then also we had a few questions about this during the Q&A and during the chat. So I also reiterate that we do have a webinar on alpha-gal syndrome coming up on June 30th. This is the red meat or mammal meat allergy that is often associated with tick bites. We have Dr. Abigail Pace and Dr. Hannah Tiffin from the University of Kentucky joining us for this webinar. So if you are interested in learning more about that, please join us on the 30th. And then we also have one final webinar on July 22nd on longhorn ticks and cattle. Lastly, once again, for anyone who is still on the call, if you have not already grabbed the link for the evaluation, we always appreciate hearing from folks about what they thought of the presentation, ideas, any feedback you have for us. We really do appreciate. So that link will also be in the chat. Feel free to grab it from this slide as well. And with that, that is all we have for today. So one last thank you to Dr. Stafford for joining us. We really appreciate you being here and taking time out of your day. And lastly, thank you to, oh, sorry, go ahead.
No, well, thank you.
All right. I was going to say thank you also to everyone for logging on for today's presentation. I hope you learned something. I hope it was informative. And have a great rest of your week and a great rest of your summer. All right, then I'm going to stop recording.